I think a few things. From a legal perspective, from a treatment planning perspective, but more from a community perspective as well. I think that the Internet of Things, using artificial intelligence and of course the cloud, is going to start connecting dentists amongst each other, to companies, to the laboratories, and this will actually help mitigate the huge responsibility that a dentist has when doing treatment planning. So by using the cloud in the future, a patient and a dentist will be able to share this information and get a treatment plan that is accepted as being the best for the patient. And I think this is going to improve the quality of dentistry overall. No longer will we have these lone dentists that are making finance-based decisions that are ruining their patients' mouths solely for the interest of profit. I also think that things will be cheaper and a lot more exciting. I'm really looking forward to it. I think the first technology that a clinic should invest in is a CBCT, cone beam computerized tomography, because it's impossible to have a clinic today and not think about implant dentistry. And it's impossible to think about implant dentistry and not have a three-dimensional image of the soft tissue and the bone. So I would say that is the first piece of technology. And then, of course, scanners, 3D printers. But it's really important to understand that if you are going to invest in the technology, you also need to invest in human resources. You have to have people on your team to use it. Too many people buy amazing technology and then don't have the time to use them for the learning curve. So I think with cool technology, you have to hire these young dentists or young technicians to help you.
Oh, it's going really well. We are really proud. We are very glad of the things they are running today. The joint venture between the Digital Dentistry Society and Area CAD-cam has been really strong, and the new format is going very, very well. We had our lectures in the same place where the exhibitors are. So after each group of lectures, all the participants could come to the stands, to the booths, just to see the devices in function. And that is perfectly the philosophy, the mission of our society is just to teach these new things that will completely change the way the dentists will treat the patients, will plan their job, their work, and communicate it with all the team that is involved in the therapy, in dental therapy. Yeah, I tried in my lecture just at the beginning of the session, just to show to the audience what is possible to do today. I meant that today is possible to, starting from the first visit up to the end of the treatment, go straight with a complete flow chart. And this is not the future, this is the present for many things. And I try to do that in my lecture, and the audience, I think, this kind of matches, I think, reach the audience very clearly.
It's interesting, there are so many different CTs, I think about 85, maybe even 90 on the market. Every day some new models appear, but they are so different. So it becomes so difficult for people to select the proper one. They actually have to have accurate information because performance can be so different. It's also interesting because it adds a factor to the previous, so there's so much variation in the cone beams. But in digital dentistry, you need also to think about the fact that you may make a 3D model. And when making a 3D model, you need, for example, good contrast resolution. So you need a cone beam that is able to depict very good alignment of the cortical bone and very good contrasted images. And not all the cone beams do that. And apart from that, you need a model where a patient is able to sit stable and not to move, because that is also going to compromise. And a third factor that is important, I think, especially for digital dentistry, is the fact that there should be no metal artifact expression, and many cone beams have a big problem with that. For many years in a number of countries, people have said not to use cone beam because of the radiation dose. They want to use minimal techniques for implant dentistry. Here we hear that everyone is using cone beam, which is, according to me, the right way to go, because that's the only way how you can properly see all the neurovascular structures. And as for implant dentistry, the patient is adult. This one-time dose for one-time implant placement will not matter too much. Of course, the doses should be not extreme, that there are machines enough who can give for an equivalent of 2 to 5 days being outside, a kind of image that can make them the perfect rehabilitation for which they can then be happy for the next 20 years.
I am a prosthodontist, so I'm mainly seeing all the benefits of digital dentistry in my field. I think that up to date, thanks to this technology, we can offer to our patient a more sustainable treatment in terms of comfort during the treatment, in terms of minimal invasive solution, in terms of treatment planning presentation. Today the patient have the chance to understand better his treatment, even we are speaking very complex treatment, and also together with the development of new materials we can offer something that today can be very minimally invasive and aimed to preserve the dentition of the patient and only to improve it. A project that actually I'm running in Italy, that is a digital smile bank. We would like to found a smile bank in which every single patient can store his perfect smile, for example, after a scanning at 20 years old, 22 years old, and so on. And we can preserve this smile if there is, for example, a trauma, pathologic events, and we can make sure the patient that we can bring the smile again, just storing these files and have all the technologies to manufacture also very thin restoration.
How much digital is in my office today? And I think that the question is generally for all the dentists which are in digital field active. It's kind of 70%. Not because we are not willing to have more, because the other 30% is not really validated scientifically. So we all want to wait for a scientific base behind those new technologies. My dream would be, of course, no GIPs, no models, like virtual library, and of course to go from the impression taking, face scanner, smile design to the final work without having any real model in the hand. That would be, of course, very elegant and precise. The digital workflow, since I am a surgeon and a prosthodontist at the same time, is huge in terms of precision of the implant placement, in terms of minimally invasive procedure by protecting important anatomical structures, in terms of perfect aesthetic, what you get by the precision of the procedures, in terms of immediate restoration in the same session on implants with prefabricated temporaries and so on. So huge advantages. Disadvantage is, let's say, we need, it's a learning curve. So again, the science behind the technologies. And yeah, maybe the financial part, but which I think we will overcome because that's moving faster than anything else.
Alors la chirurgie guidée, c'est d'abord le moyen, si vous voulez, d'être à peu près certain de placer votre implant par rapport à un projet prothétique, ce qui est finalement l'objectif de tous les traitements, parce que les patients viennent nous voir pour avoir des prothèses et pas pour avoir des implants. Et puis le deuxième objectif, c'est un objectif de réduction de la difficulté chirurgicale. C'est-à-dire qu'on va être capable, avec la chirurgie guidée, là où on faisait des chirurgies à grands lambeaux, de faire des chirurgies sans lambeaux. Là où on faisait de la chirurgie additionnelle, des greffes, des choses comme ça, aujourd'hui on va être capable de les éviter. Donc ce sont les indications majeures. C'est-à-dire qu'on va véritablement dans une évolution naturelle de la chirurgie qui va toujours du lourd vers le plus en plus léger, vers plus de confort pour le patient et le praticien. C'est essentiellement ça l'indication pour nous. Dès que le cas devient un petit peu complexe, soit sur le plan esthétique, soit sur le plan chirurgical, le coût s'efface parce que vous avez une réduction du nombre d'interventions, parce que vous avez une prédictibilité du résultat, vous avez moins de corrections à faire, vous avez moins de séances. Non, le prix, quand l'indication est bien posée, s'efface complètement.
I think that the new technology we can reduce several traditional passages and so increase the accuracy of the digital workflow and combine the new technology with the new monolithic material. We can complete the digital workflow in accuracy way.
And maybe we can add, like, since you asked about some limitation that we still need to overcome, maybe of course we need a learning curve, so we should start with simple cases in order to get like expert, competent and consistent in what we're doing. And discussing about limitation probably while it's when the span is becoming wider, so when we are approaching full arch cases it's not always easy to be predictable, not because we don't have instruments such as intraoral scanner that are not accurate enough compared to the traditional workflow, but we're still missing some dots in the overall workflow in terms of like digital models, in terms of analogs, so still there are some variables that we still need to study more to be predictable in full arch cases. So, because of the learning curve, since like every new thing that is entering in dentistry, we need to learn how to use it, we need to understand which are the benefits, we need to understand which are the limitations and the strategies that are making us performant and consistent in what we are doing. So, students that have the opportunity to start from the university will get a lot of advantages in the future that for sure is going to be a digital future.
The students can detect the information in easy way and so can do a diagnostic approach in a better way respect the traditional way.
Yes, I think that the future is yet a reality because in our daily practice we can use digital procedure using a 3D printer machine to obtain our bone grafts customized for our patients. So other applications are full service from company that with a bigger machine as a laser sintering machine we can obtain customized implants, dental implants or customized maxillofacial implants for bone surgery, and so is yet a reality, and I think that in the next future will be possible to print directly in our practice the bone graft. The material is an important key factor in our daily practice as bone substitute. So in the new era of bone tissue engineering, it's important to use synthetic biomaterials because are without risk for our patients and technologically modifiable always during our procedure or during our research development. So synthetic biomaterial is the right choice for this new digital procedure.
On VR, you have only the digital space, a digital world, but with augmented reality, you have a mix of digital and physical, and they can interact with each other. This is the principal difference. Well, the technology evolved very, very fast. Every 8 months, more or less, we completely evolve and change all or become very better. So in the next 2 years, no more, we have all this technology on their studios.
Okay, can aid the surgeon in the sense that the surgeon can plan before the surgery the position of the implants and is able in real time to see the position of his drill and to follow the pre-planned position on a computer like an engineer. Yes, for me this technology could be considered the future because it's the best technology that could be used in combination with augmented reality. All the technology in our field of work in medicine go to augmented reality, so I think this could be the best instrument to combine with it.
So I think it will be solved when we can get a real good quality of imagination. And I think it can be possible when something new technology comes, because with the video technologies there is some problem with the old technology makes a little bit distortion, and this is bad. We need really high quality. Maybe with some ultrasonic solutions would come, so I hope maybe soon. So as I told, I started digital dentistry in 1993. At that moment it was something wow. And I have this CEREC one machine, it's like a space shuttle at that moment. And I still observe my patient 20 more years, they use these materials. The precision was not so good, but it still works because it's porcelain is nice, good fit, and it's still working. So I demonstrate today one of case of 21 year observing. And with nowadays, the technology improves a lot. And I think soon, but still in my practical daily work, I feel there's depth. I can't make over. But computer technology run, so I hope. So I don't want to be a computer specialist. I want to be a dentist, chairside dentist. So I want to press button and get a result. That's it. And also my patient want the same. So we will wait this moment. Till now we combine traditional technology and cad-cam. And it's okay for us. We try to do the best.